A very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on Ankylosing Spondylitis. I'm thankful to all the participants from all over the country who have taken out their time and are attending this evening talk. Pharm D Community has been created with a charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my co-committee members. Thanks to Kuldeep, Pooja, and Vaishnavi. I would also like to thank the recently joined family community members. It's my pleasure to release the flyer of our next webinar. The registration link for the same will be posted in the chat box of both YouTube and Zoom. So our next webinar is on post-traumatic stress disorder, and the speaker is Dr. Harish Shetty, sir. We also do have a series of webinars, that is an e-certificate course coming up on gastroenterology, which is to start on 13th of February. So interested participants can register for the same. I'm thankful to our speaker, Dr. SUSHANT SHINDE, sir, who is one of India's eminent rheumatologists. I'll hand over the session to my teammate, Marina, to introduce our speaker for today evening.
A very warm good evening to one and all. On behalf of Pharm D Community, I welcome you all for today's session on ankylosing spondylitis. We are privileged to have with us one of the renowned rheumatologists, Dr. SUSHANT SHINDE, sir. Sir has completed MBBS from Krishna Institute of Medical Sciences, Karat, and MD in Internal Medicine in All India Institute of Medical Sciences, New Delhi. Sir was a senior resident in Department of Medicine, AIIMS, New Delhi, and research officer in Rheumatology Unit, AIIMS, New Delhi. Sir has been granted with European Alliance of Association for Rheumatology certificate. Sir is a physician and a rheumatologist in Room Derma Clinic, Dadar, Quest Clinic, Goregaon. Sir is a medical educator in Quest Medical Academy, as well as a founder, director, and trustee of Ramvardhani Health Foundation. With this brief introduction, I request Sir to proceed with the session. Over to you, sir.
So first of all, I would like to thank all of you to the DPharm community. I think you're doing an excellent job. This is my second time as a speaker at your forum. And I would really like to thank you all for this invitation and for all the participants and audience who are there for listening to this webinar. The topic that I'm going to discuss today is ankylosing spondylitis. In a very simple outline, I would like to describe how we see this topic, what are the common problems that we encounter when we see these patients, and I'm just going to spotlight my video so that everyone is able to see this. Okay, so in a simple nutshell, I will try to describe how we see these patients having ankylosing spondylitis, what are the common problems that we encounter, and what are the therapeutic options that really are in front of us. I understand that a lot of questions might be there. If you listen to the topic for the first time, there are obviously bound to be questions. If you have already read up this topic, if you have already studied this topic in details, there can definitely be questions. I would like to take your questions, and so I would like to dedicate some time towards the Q&A. So let's begin with some basic aspects. I'm going to speak as if I'm speaking to the student community. Of course, if there are by any chance practicing doctors over here, or by any chance if there are patients listening to this, please note this is not being directed towards you. I'm speaking for the student community. So I'm going to share my screen, and I'm going to pretty much write down what I think are important aspects that we need to know when we are talking about spondyloarthropathy. First of all, we are talking about ankylosing spondylitis. But when I think about ankylosing spondylitis, really speaking, this comes within an umbrella diagnosis. It is a part of some other diseases which can also come under what is known as spondyloarthropathy. So when we talk about ankylosing spondylitis, really we should not ignore that it's a part of what is known as spondyloarthropathy. Spondyloarthropathy, spondyloarthritis, or in simple words, SPA. Now, what is this SPA and why do we need to know about SPA? Now, understand that maybe a decade or two back, Ankylosing spondylitis was equivalent to saying that a patient would have bamboo spine, which is a complication of ankylosing spondylitis. That means eventually a patient who has ankylosing spondylitis, his entire spine is going to get fused. But that was pretty much a stage where not much could be done. If the spine has already undergone fusion, how much can you reverse it? Not much. What are the drugs that you can give after that? Not much. So we have been trying to find out, can we intervene at an earlier stage? Remember, that's how science goes ahead. So I've been trying to find out, can we intervene at an earlier stage? And those efforts led to a revision of our diagnostic techniques somewhere close to 2010. And this word started becoming important, known as spondyloarthropathy. So you might think of it this way, that there are a lot of patients of spondyloarthropathy. Some of them would evolve towards ankylosing spondylitis. Some of them might not actually have fusion of the spine if they get good therapies, and some there could be other markers, some genetic reasons also why they don't really progress towards ankylosing spondylitis. So before we say that we are seeing a patient of ankylosing spondylitis, it is important to see whether the fusion has really occurred. They are at risk of the bones getting fused, but it is not necessary that everybody develops fusion of the bones. So what is this spondyloarthropathy, and what will happen when it progresses towards ankylosing spondylitis? Well, understanding spondyloarthropathy becomes easy if you remember the mnemonic. Now these are the findings that I expect to see in a patient. These are simple things which I ask in history, which make me think that, okay, if the patient has this, then I'm probably dealing with ankylosing spondylitis. Now what are those things? Now it's easy to remember because it has a mnemonic. Now I'm talking about spondyloarthropathy here, and then I'll say what is specific about ankylosing spondylitis. A lot of things would overlap over here. So first, pardon me, I'm going to cough a little, sorry for that. So when we think about spondyloarthropathy, the first thing we need to remember, the mnemonic is ABCD. A means the patient is going to have axial symptoms. So when I say axial, that means the patient is going to have predominantly central features. Remember, we are dealing with arthritis here. So a patient who has spondyloarthropathy or ankylosing spondylitis will not come to you saying mere haathon mein dard hai. He will not come telling you that mere पैरों mein dard hai. He will most likely come to you with axial symptoms. And that axial symptoms brings us towards the most common symptoms that brings them to you is backache. That they are going to come to you with the features of backache. And this backache has some very characteristic features. It is going to be a lower backache, typically in the lumbar region, the lower part of the back. This back pain is typically going to last for more than 3 months. So it won't be a backache कि मुझे कल दर्द हुआ, आज ankylosing spondylitis तो नहीं है, नहीं. Ankylosing spondylitis, I will think if the patient has backache which has lasted for 3 months or more. So it's a type of chronic backache. This backache will have one very specific feature, that it would be worse when the patient wakes up in the morning. It would be worse when the patient is going to rest. But it is going to improve the moment the patient gets up and starts moving around. It is better on the days when the patient is exercising. So it is going to improve with exercise, and it is going to worsen on rest. Very, very, very important symptom for us is that this pain is going to improve on exercise, and it is going to worsen when the patient is going to rest. Now think about this. Most of us at some point or other in our life have had backache. And whenever we had backache, we have rested out. In fact, you might have heard that we tell a lot of patients who have backache that go for a bed rest, you will be better. Not this patient. The moment you tell this patient to bed rest, the moment this patient rests for a lot of time, you might find that the disease actually starts worsening. They start doing worse when they are resting. They're better when they're moving around. They are better when the day proceeds, but they are worst in the morning hours. They'll tell you that there is severe morning hour stiffness. My back is worse and stiff in the morning hours. These are also patients which have one very peculiar problem, that these are going to be usually young individuals, and their backache typically starts when their age is less than 40 years. In fact, this less than 40 years is just a number. I would say most of them come to us usually in the age of 15 to 25 years when their first symptom starts. Of course, less than 40, but in fact, this early on, they are young kids who are going to come with pain. Most of them are going to be men. Far more than women have ankylosing spondylitis or spondyloarthropathy. Now, these features which I have written down together, lower backache, which is more than 3 months, worsens on rest, improves on exercise, typically seen in a young individual. This kind of a backache has a name. This is called inflammatory backache. This is inflammatory backache. Please remember this word. Whenever we are dealing with ankylosing spondylitis, we have to differentiate it from other causes of backache. Please remember, when you see patients coming with backache in the community, almost you can say 95 to 99% of them do not have ankylosing spondylitis. They could have other causes of backache, like they could have slip disc, they could have lumbar canal stenosis, they could have lumbar spondylosis, they could have trauma associated backache. All those are mechanical backaches. All those can occur at any age, but typically more than 40. All those patients will do well then when they rest. But these 1% to 5% patients who don't fit into all of that, they will fall into spondyloarthropathy. So your history of backache is very, very, very important, right? Next is going to be, of course, the question of what are the other features that these patients could have. So the other features are easy to remember. These patients can have other associated diseases like Crohn's disease. Crohn's disease is a form of inflammatory bowel disease, so they could have that. These patients could have dactylitis. Dactylitis means there is going to be a swollen finger. In fact, the swollen finger looks like a hot dog. So it's also called a hot dog finger. It looks swollen up like a hot dog. They could have other areas of pain, what are known as enthesitis. Enthesitis means what? Enthesitis means the pain is at that area where a tendon or a ligament attaches to a bone. A tendon or a ligament where it attaches to the bone, that is the area of enthesis, and these patients would have pain in that area known as enthesitis. And this enthesitis typically would present to us with heel pain. So typically you have a young boy coming to you saying, I have backache and I have a heel pain. Think in terms of a possibility of spondyloarthropathy, ask for history of inflammatory backaches, and think in terms of ankylosing spondylitis. There can be other features, like patients can have other family members who are involved. Very recently, yesterday I was in the OPD and I met a patient, 3 members in the family having ankylosing spondylitis. In fact, I should correct myself, not 3 in the family having ankylosing spondylitis, 2 in the family having ankylosing spondylitis, and the third one, their sister, having another disease which falls within the spectrum of spondyloarthropathy. So I told you in the beginning, spondyloarthropathy can present with AS, it can present with other subtypes also, but all of them can run in the family. There can be other members in the family who could be involved, who could have similar diseases, related diseases, and we need to take a good history when we are trying to diagnose them. These patients could have genital ulcers, that is where G comes in. These patients could also have a test, that is where H comes in, known as HLA-B27. HLA-B27 is an allele. It is a genetic marker which we find in the blood, and presence of HLA-B27 helps us to diagnose ankylosing spondylitis. These patients can also have other features like involvement of the eyes, known as iridocyclitis or uveitis. And a lot of them are going to be young patients, so they have juvenile onset. Juvenile onset. If I run through them again, it's easy to remember what kind of a history are we taking. We are asking for the history of pain, and we are asking where is your pain. It has to be more central than peripheral, more axial than peripheral. We are asking for backache, and we are looking at the history of inflammatory backache. So we need to ask very specific questions. What kind of pain do you have? We are asking them associated features like, do you have bleeding in stools because of Crohn's disease? Do you have any swelling in your fingers? Do you have heel pain? Do you have any other family members being involved? We ask for any eye symptoms. When did it start? And then, of course, we test for HLA-B27. Now, whenever we look at spondyloarthropathy, please remember the most common form of spondyloarthropathy is AS. So if people have SPA, a lot of these patients opt of SPA would have ankylosing spondylitis. Now, what is specific about ankylosing spondylitis? Now, what is interesting about SPA and ankylosing spondylitis, this is my spine. If I say this is my spine, with of course the intervertebral disc in between, this spine ends at the level of sacrum. This spine ends at the level of the sacrum. So spine का सबसे नीचे वाला भाग जो है, that is the sacral bone. This is the sacral bone. And on both the sides, you have the iliac bone, which is going to start. On both the sides, you have the iliac bone, which is going to start. Now, these patients, remember, have lower backache. They have lower backache because their inflammation, the area where they are having these damages, it is all starting in this area. They have inflammation in what is known as the sacroiliac joint. So if you're writing down what I'm saying right now, please remember the classical feature of SPA as well as ankylosing spondylitis is that they have sacroiliitis, that they have inflammation of the sacroiliac joint. So if I'm doing an X-ray, if I'm doing an MRI, very important for clinicians is that when we are doing an X-ray or MRI to diagnose ankylosing spondylitis, we should not be asking for lumbosacral joint. I don't want this. I want this area. I should be asking for an X-ray or an MRI of the sacroiliac joint. An X-ray or an MRI of the sacroiliac joint and HLA-B27. These are two classical investigations that help me to make the diagnosis. Typically, these patients would have bilateral, both sides sacroiliitis. Bilateral sacroiliitis with the presence of HLA-B27, we should think this is a patient having spondyloarthropathy and ankylosing spondylitis. But unfortunately, remember, these are young kids. Someone could be 20-year-old when the disease first starts. This is going to be excruciating pain. At the time when there is pain, initial stages, there is inflammation within this joint. This is an injury happening within the joint. There are a lot of inflammatory markers which are responsible for this pain. One of them is tumor necrosis factor or TNF. Other such inflammatory cytokines which are responsible for causing the pain to progress are interleukin 17. These are important names, tumor necrosis factor and interleukin 17. These are important names because now we have targeted therapy against these cytokines. Now, the important thing is initially there is going to be inflammation in this joint. There is going to be an orchestrated damage within the joint. But later on, if the disease is not controlled, if the disease progresses, this continuous inflammation would lead to calcium deposits and fusion of the joint. This fusion of the joint, the sacroiliac joint might actually fuse, is going to be the later stage of the disease. But in ankylosing spondylitis, it's not going to restrict itself to the sacroiliac joint alone. Eventually, as the disease progresses, you might find that such inflammation is going to happen in these areas also, between the lumbar bones, lumbar vertebral bones, and it can start climbing upwards right up to the mid thoracic region, to the cervical region, and the patient eventually would have the entire spine fusing together as one big block. That is the stage where we call it bamboo spine. We call it bamboo spine because now, if you have fused all the joints, the spine cannot bend forward, it is straight. If the patient has to turn around, patient can't do that. If the patient has to bend forward, he cannot do that. If the patient has to look upwards, there is a restricted mobility that the patient is going to experience. That stage is when we would typically use the word ankylosing spondylitis. That is where the fusion has occurred. That is where the bamboo spine has occurred. Our idea in medicine today is that we should try to identify these patients as early as possible, try to start them on therapy as early as possible, give them a good quality of life, and ensure that the damages are the least possible. I wouldn't say that our treatments are absolutely foolproof. We don't have absolutely foolproof treatment yet, but yes, we are doing much better than what we used to do earlier. Patients can have much longer symptom-free intervals, and there are much better medicines today than what we had maybe a few years back, right? Maybe a couple of decades back, I should say, right? Now, let me go to the next step. As a clinician, if I'm seeing this patient, my next concern is confirming the diagnosis. So what do I do to confirm the diagnosis? And of course, then what do I do to start therapy after that? Right. So in a quick nutshell, how do I diagnose these patients? Diagnosis of ankylosing spondylitis. If I see a patient and I've suspected ankylosing spondylitis or SPA, I'm going to advise the following investigations. One, I need to look at the markers of inflammation. So along with CBC, complete blood count, I'm going to look at erythrocyte sedimentation rate. Usually ESR is going to be elevated in inflammatory states. I expect that over here. I'm going to look for C-reactive protein, CRP, and I expect that also to be elevated over here. Since I'm going to start the patient on medicines, I want to look at his renal function, at least a serum creatinine, and I want to look at his liver functions to see whether the drugs that I'm going to start, the patient is in a position to tolerate it or not. These are baseline investigations. I might repeat them later on also as therapy continues. But for diagnosis, as I've said, I would require HLA-B27, which is a blood test, and I would require either an X-ray or an MRI, depending on the stage of the disease. If it is very early, X-ray might not pick it. I might require an MRI of the sacroiliac joints. There might be additional tests which might be required in some cases, depending on from case to case. Like in some cases, I might further require a detailed ophthalmology evaluation because these patients can have associated uveitis. Sometimes I might require a chest X-ray because some patients can have associated disease like interstitial lung disease where there is fibrosis happening inside the lung. So on and so forth. On case-based basis, I might require further evaluation. I might sometimes require to evaluate the gut, so on and so forth, depending on the specifics of my case. But now let's turn towards that part where the treatment starts. How do we treat these patients? Of course, we cannot treat anything without proper diagnosis. We have to remember treatments would come secondary to diagnosis. We cannot miss a diagnosis and expect that the patient will be fine if I treat him. What am I treating really then, right? So my diagnosis has to be on the right track. Then comes the therapy. When we think of therapy, we think in terms of two broad strokes. There are conventional therapies, the older therapies, not bad, just old, they have been there for a long time. And the newer advanced therapies, what are also known as biologic therapies, right? So let's see how this algorithm works. What do we start with? Now, one thing we have to always remember that therapy means more than drugs. So there is a big role in case of ankylosing spondylitis of physical therapy or physiotherapy. So physiotherapy, remember, these are patients who are going to be better when they're moving around. So they need to be guided to improve their range of movement. We need to tell them what kind of exercises will help them to improve the range of movement. This physiotherapy will also help to decrease the level of pain and stiffness that they have. The pain and stiffness also improves when good physiotherapy is done. Physiotherapy is also going to help them preserve the strength of their joints, especially the strength of their core muscles, their back muscles. It is also going to help them in maintaining their posture. In fact, I tell all my patients of ankylosing spondylitis or spondyloarthropathy, visit your physiotherapy as frequently as possible, as frequently as possible. Engage in regular exercises. No, I had this once I had this opportunity to meet a person who has ankylosing spondylitis and also happens to be a doctor. It's a long backstory. I don't know where that person is right now. But at a time when I met him, he was a medical intern. And I happened to be delivering a lecture, and that's when he came up to me and spoke. Said that he has ankylosing spondylitis, but he looked quite fit. He was doing well. And when I asked him how do you go about your physiotherapy, he said, I do physiotherapy regularly, but I also exercise regularly. I go for jogs almost 3 kilometers every day. Of course, that's not immediately. He started it gradually, and now he has improved his stamina to that. He swims almost every weekend. He says, I go for swimming. So that kind of commitment is really appreciable, but at least half of that commitment is something I would say all my patients require. I very often quote this person when I see patients, who say that we can't exercise. No, I think exercise is a really important part of therapy in ankylosing spondylitis, right? So once the patient has been convinced that he requires good physiotherapy, of course, our role comes in with pharmacotherapy and the conventional drugs that we can ask for. My first choice, if someone is to ask you what is the first choice in when you see a patient of AS, the answer is non-steroidal anti-inflammatory drugs, without a doubt, right? The first choice are NSAIDs, non-steroidal anti-inflammatory drug. Now, a lot of people have a lot of reservations when it comes to NSAIDs. Some of these reservations are correct. Some of these reservations are blown out of proportion. So let's start with what do we give? Amongst the NSAIDs that we can give these patients, the first is very often what is commonly used in our country is indomethacin. Indomethacin is a good and has a good anti-inflammatory action. We can start with anywhere somewhere close to 75 milligram per day, and then we can taper the dose. In some cases, they might require higher doses, but very often 75 milligram per day is usually what is given. You can go up to 150 milligram per day. You can come down up to 25 milligram per day. So I should write this down. You can go up to 150 milligram per day. And if the patient starts doing better, we can go up to 25 milligram per day. Apart from indomethacin, one drug which I frequently use is etoricoxib, which is a COX-2 inhibitor. Similarly, etoricoxib has a range. Very typically, I would use in a dose of 90 milligram per day, but of course, there is a higher end. We can go up to 120, and a lower end, we can go up to 60 milligram per day as a dose. We can use naproxen, we can use naproxen, you can use other things like diclofenac, but these two remain the most common. When we are using indomethacin, of course, we have to be careful that the patient can have GI adverse effects. Those are lesser with etoricoxib. But what really concerns people is if you're going to use them, how long are you planning to use them? Well, the answer to that is in the initial stages. Remember, these are young people. These are not people who are cross 40s. Most of them are young. They are 15, 20, 25. They're young people. They are not post 40. They are not diabetics. They are not hypertensive by the time when we are seeing them. There is enough data to say that there is good safety of these drugs in this age group. we can use it under monitoring. Now, the underlying word here is under monitoring. I've already seen the serum creatinine, that is the kidney function. I'm going to see that eventually every few weeks. But under monitoring, I can use these drugs for a few months, and up to 2 years also can be used. I'm not saying I'm using it in all patients right through 2 years. I'm saying up to 2 years, it can be used under monitoring. So when I start these drugs, needless to say, after the first 3 to 4 weeks, I'm going to ask for serum creatinine. And in my practice, I'm now telling you what I do. I would give these drugs at least for 1 to 2 months straight away. Most of the patients, when they come to us, they would come in severe pain. I would use them regularly for 1 to 2 months to get the inflammation down, to get the level of pain down, to start helping the patient to mobilize more, to do better exercises. Remember, there is also evidence to say that use of these drugs reduces the rate of calcification. Remember, they are at risk of calcification of their bones. That risk is also going to come down with the use of these drugs. Of course, not completely negated, but it comes down with the use of these drugs. I strongly believe these drugs get underutilized or wrongly used. Very often patients are told that you have been given painkillers and patients stop it. No, it is important to realize these are anti-inflammatory drugs. They really change the natural history of the patient in some patients. It might reduce the rate of calcification. That's important to remember, right? Of course, we cannot overuse. We cannot say that this is the only drug I will use. That's not sufficient, but NSAIDs do have an important role in these patients. After NSAIDs, what next? Well, the answer would change in context of the country. In this country, in India, after NSAIDs, what next is other conventional DMARDs. Not across the world, but in India, definitely. After NSAIDs, what we can use are other conventional drugs. And amongst the other conventional drugs, what is first preferred is sulfasalazine. Sulfasalazine is a drug that it's given orally. We would start with a dose somewhere close to 1 gram per day. And then we would usually within the next 3 to 4 weeks reach the dose of 2 to 3 gram per day. And I would like to stay at this dose of 2 to 3 gram per day for the next few years. If the patient responds to it, I would want the patient to stay at this dose for the next few years. Not always accepted, not everybody agrees. What I'm going to say to next is the role of methotrexate. Though there is some data to say that yes, it works, but there are a lot of people who say that maybe it doesn't work here. It works better in rheumatoid arthritis. So be it, but without going into any further controversies about it, usually in a dose of 15 to 25 milligram per week. You know, this methotrexate is not a per day therapy, it's a per week dose, either injectable or oral, whichever way, can be used in cases of ankylosing spondylitis or spondylarthropathy. Of the two, sulfasalazine is more accepted. This is also used in India, but not everybody agrees that there is any role or that it offers any benefit. Of course, when we use these drugs, we would want to see whether the patient improved. If the patient does not improve in the first 6 to 8 weeks, usually there is no sense continuing the drug beyond that. Right? Once you have given the full dose, 6 to 8 weeks, we want to see some improvement in the patient. Now, remember, both of these drugs, one thing that everybody would agree on is that these drugs work better when the patient has axial as well as peripheral symptoms. Remember the first thing that we said, that these patients have axial symptoms. That means their symptoms are predominantly in the spine. But that's not true for everyone. There are going to be patients who have symptoms in other joints like the hip joint, the ankles, wrist, sometimes fingers, sometimes shoulders. Patients who have such peripheral joint involvement, in those cases, most people would agree that sulfasalazine and methotrexate do a better job. But what if I have given NSAIDs, the patient is doing physiotherapy regularly, we have used sulfasalazine and we have used methotrexate if we required, and yet the patient has not improved. What then? In that case, in India, after this point, we would consider the role of biologics. Now, what are biologics? Biologics are targeted therapies against these cytokines which are responsible. And there are two broad categories of biologics that are available and used in India. I'm going to restrict to what is done here. There are two broad categories. First are anti-tumor necrosis factor, anti-TNF. And second are anti-interleukin 17. So there are two broad categories which are used in India. Of the two, anti-TNF are the ones which are older. Anti-TNF are the ones which we have more experience with and are more frequently used. What are the examples of the anti-TNF? Most of you might have heard about them. The oldest one is infliximab. It's a chimeric compound, infliximab. Typically, it is given intravenously in a dose of 3 to 5 milligram per kg. And after the initial loading dose, it is given every 2 monthly. So once in 2 months after I've given the initial loading dose, once in 2 months, infliximab is the drug that can be used. There are other drugs also which are all subcutaneous apart from infliximab. Examples could be etanercept, adalimumab, golimumab. There isn't really much to say which of them is the best. It will very often come down to the preference of the patient, the preference of the treating doctor, and of course, sometimes some other specific parts which might contraindicate one of the drugs. But by and far, they are almost equally effective. They almost have the similar side effects. Cost-wise, they might differ. Remember, these are more convenient for the patient because of the subcutaneous therapy. If you ask me which one I would prefer, I would very often say infliximab. I have seen that it works perhaps the fastest. In the long term also turns out to be quite cost effective for the patient because it's once in 2 month therapy. But of course it has a loading dose, so sometimes the initial cost might be a reason why a lot of patients don't really go for it. But my choice would go over here. What is very frequently used nowadays is adalimumab. One of the most popular out of these right now is adalimumab, right? Because of its convenience and because of its lower cost than the rest of them right now. Now, when we are thinking of anti-TNF, one of the things that we need to bother about are their adverse effects. And when we think about adverse effects, the top of the list is adverse effects of infections. That all of these are going to be significantly immunosuppressive agents. So they are going to predispose the patient towards infection. So before we give anti-TNF, we have to screen the patient for underlying infections, especially in our country, big question, tuberculosis. If the patient has tuberculosis, we cannot give these drugs. We have to screen the patient whether the patient has tuberculosis. And if the patient has tuberculosis, these drugs cannot be given. Any active tuberculosis, we have to treat it first and then consider giving this therapy. Similarly, other infections like viral infections, hepatitis B, hepatitis C, and HIV are relative contraindication. You can't say that we can't give it, but you have to correct it, suppress that virus, and then only if required give this. I would avoid it as far as possible when these viruses are concomitantly present. That brings us to the other side. The other side is interleukin 17. Interleukin 17 inhibitor is secukinumab. Secukinumab, that's the only one which is available in India, secukinumab. Again, it is initially given as a loading dose once in a week, but after the loading dose is done, you are going to give it once in a month. So every once in a month, you are going to give secukinumab. Secukinumab, you should be aware, is a drug which is now used in spondyloarthropathy, but when it was first launched, it was actually launched for a subtype. Now that brings me back to the first slide. In the first slide, I told you that spondyloarthropathy has ankylosing spondylitis as one part, but there are other parts, and one of them is what is known as psoriatic arthritis. Psoriasis associated with arthritis. There are others as well, right? Now, this secukinumab was initially launched and is still preferred for what is known as psoriatic arthritis. That means patients having the skin disease of psoriasis and associated arthritis. But it is also being used now in ankylosing spondylitis. It has shown effects in ankylosing spondylitis as well. But if someone asks me where is my first choice, I would say my first choice for AS is anti-TNF. And for spondyloarthropathies, yes, for psoriatic arthritis, yes, we can use secukinumab. Someone who has been given anti-TNF and does not improve, an AS patient, I might go ahead and consider secukinumab in that patient. How long should I continue this therapy? Now that's $1 million question. We don't really have an exact answer. The answer would change from patient to patient, but a minimum therapy, I would tell you, if I'm going with conventional drugs, would be years. It would take 3 years, 5 years, maybe longer, and the patient needs to be on that therapy for a long time. Any long-term therapy means we need to monitor. We need to be on a watch out for adverse effects. I can tell you under monitoring adverse effects are not very common, but yes, they do exist. And if the adverse effect occurs, we have to taper the drug, treat the adverse effect, then reconsider when is the right time to start the therapy and restart it again. So a lot of our work is monitoring in these patients. I should also say that there is a lot of psychological burden that these diseases carry. These are young individuals, their lifestyles are severely limited because of the disease. So we need to take care that they are not suffering from anxiety, they are not suffering from depression. And if there are comorbidities, then the right therapy, right referrals to a psychiatric colleague at the right time might help. I'm not saying it's always there, but I'm saying it is something we have to watch out for because the possibilities does exist. And in the long term, I say exercises, good therapy, a positive frame of mind, and patients would do in the long term. Most of the patients do well in the long term. There are, of course, unfortunate few who would not improve, who would continue to worsen despite a therapy. But again, we should not be judging the entire disease by just few examples. If we look at the journey of AS in the last 20 years, I think it's been a good journey. A lot of people are doing well. They are living pain-free life. They do require long-term therapies. Cure is a word that we do not use yet, but please understand, when I don't use the word cure, I don't mean हिंदी में कि patient ठीक नहीं होगा. I want this point to be understood clearly, that when I say that the disease does not have cure in medical English, I don't mean in Hindi that means कि patient कभी ठीक नहीं होगा. In Hindi it means कि patient will be pain free, and a good chance of that. The patient will have a near normal lifestyle, a good chance of that. Some patient, fortunate one of them, might go off medicine at least for a very long period, good chance of that. But is there a possibility that I give a drug once and the disease goes away and never comes back? That is cure. That I say cannot happen. But the patient can have a good quality of life. The patient should have a positive approach to his life and will stay good. That can occur. So if you ask me Hindi mein ki patient theek hoga kya, I might actually be tempted to say yes. But if you ask me in English, is there a cure? I would usually say the scientific answer, no, there is no cure. Right? So with that, I would like to rest my case. And if there are any questions, over to you organizers, I would like to take the questions.
Thank you so much, sir. Thank you once again for delivering such an informative and elaborative session on ankylosing spondylitis. As we were streaming live on YouTube, we have received a couple of questions, so we'll be taking a couple of them. So the first question, Mihir Chachar is asking, what is the alternative therapy if a patient has got TB or other infections?
So we need to correct those. For example, if a patient has, so in tuberculosis, I did not go there much, but if the patient has active tuberculosis, let's say the patient has lung involvement with TB or any other extra pulmonary involvement with tuberculosis, we need to start him on the 4-drug ATD, anti-tuberculosis therapy, complete that therapy, and then preferably start with the biologics. If it is very urgent, then I would still wait for at least 2 months period, the intensive phase to get over, and then start anti-tuberculosis therapy, then start the biologic therapy. But usually I will not take that risk. I would wait for the patient's treatment of tuberculosis to complete and then start. Till that time, I would be comfortable giving him non-steroidal anti-inflammatory NSAIDs and sulfasalazine, not even methotrexate, but NSAIDs and sulfasalazine is what I would continue. So same applies with everything else. With hepatitis B also, we would usually prefer that the patient is on tenofovir, the viral loads as non-detectable. The the hepatologist is kept in the loop, and we understand that the patient has understood the risk-benefit ratio. And only when very necessary, I use the drug. Otherwise, I would avoid it.
Okay, thank you so much, sir. So the next question is from Angad Bhatia. Angad Bhatia has mentioned that a patient who is suffering from lower back pain since past 6 years is also tested HLA-B27 positive and was recommended to go for swimming, but has experienced a increase in the pain when swimming is discontinued. When the patient stands, the patient bends and slowly develops normal posture. Prescribed drugs include indomethacin and diclofenac. The patient needs someone's assistance when he tries to wake up due to the pain. The pain still remains when the medications are taken. It decreases, but it worsens in the morning. So what can be recommended for the same?
I can say 3 words: meet your rheumatologist. Because what you're describing is if it is AS, again, just because HLA-B27 is positive, we can't assume it is AS, but a lot of features you have described are of AS. Then there is, as I've said, there are other therapies available. They need to be, the patient needs to be evaluated by the rheumatologist who is seeing. and further therapies I think can be started. So I think I can only in broad strokes say this much. The specifics of the case after evaluation, the treating doctor can kind of discuss with you. But yeah, I think meet your rheumatologist.
Yeah, thank you so much, sir. So the next question is from Prajakta. She's asking why ankylosing spondylitis is more common in men than in women.
I don't know. I don't think anybody knows. So we don't know a lot about the disease. So I don't think I can answer that question. Sorry.
Okay, thank you
We
so
do
much,
know
sir.
that it is close to 9 is to 1. So you're right that close to 9 is to 1 is the ratio. 9 men to 1 women is what we see. We do know that in women, overall, the disease tends to be slightly better than in men, as in form of the level of fusion, the level of discomfort tends to be slightly better in women than it tends to be in men. But why? I don't think we know that answer. At least I don't know the answer.
Okay, thank you so much, sir. The next question is there any chance of infection of backbone due to ankylosing spondylitis?
No, it is inflammation, not infection. Infection would be typically, I mean, the bone infection is typically tuberculosis. So no, and they look very different on MRI. So no, infection is not, I mean, not a part of AS.
Okay, thank you so much, sir. The next question is if a patient is having ankylosing spondylitis and anterior uveitis and is also diagnosed with IBD, then how can we manage this patient?
So what you just now described are extra-articular manifestations. So as you said, as you saw when I was writing that ABCD, there was Crohn's disease in that, that is inflammatory bowel disease. There was uveitis, iridocyclitis, which is what you have described as anterior uveitis. So both of these are extra-articular manifestation. They are beyond the joint which has got involved. Ideally, patients who have extra-articular manifestations should be on biologic therapies. That is ideal. Now, it of course depends on how severe it is, and of course, other factors like if there are contraindication, the cost implications of the therapy, age of the patient, other comorbidities of the patient. So many things will come into place. But if I assume that the patient is otherwise fit and doesn't have any other reasons to that we can't give biologics, then a patient who has active inflammatory bowel disease and active anterior uveitis with AS should be considered for anti-TNF therapy. Amongst the anti-TNF therapy, you might have noted that I said that there could be contraindications or no, we avoid some therapies some places. So yes, if we look at the anti-TNF therapies, a patient who has especially inflammatory bowel disease, I will avoid in secukinumab, I will avoid etanercept. One of these three, infliximab, adalimumab, or golimumab, would be the ideal choice for a patient who has what you said, AS with uveitis, with inflammatory bowel disease. Either infliximab, adalimumab, or golimumab becomes a good choice.
Okay, thank you so much, sir. The next question is there any role of surgery in the initial stages of the disease?
Surgery, you said, sorry?
Yeah, the role
Not
of
in the
surgery.
initial stages, later stages, sometimes people might require some stabilization therapies, but again, not very frequently done. But initial stages, no, no role of surgery. Even in later stages, very often not required. But sometimes if the patient has some spinal instability because of the disease or disease ke baad, sometimes, if the patient's spine has become fused and the patient has, has a fracture, has a high risk of fracture because the mobility is restricted and maybe the patient falls down, he might have an instability or an unstable fracture there. Those patients might require surgery, but early stages, no role of surgery.
Okay, so the next question is how effective are anti-inflammatory foods in the management of the condition?
Food, you said?
Yeah, anti-inflammatory foods.
Very controversial question. I mean, it's a good question, but I'm saying controversial in the sense that there isn't enough data. So there are a lot of people who believe that certain kinds of food might help the disease progression. There are a lot of people who believe that there are some foods which worsen their outcomes. But study after study and meta-analysis after meta-analysis shows that there is not much that has been shown to really correlate. I mean, I give this example to my patients that a lot of patients feel that मुझे खट्टा खाने से तकलीफ होती है. It's a common thing, at least in the part of the country where I stay. And I ask them, have you been to other parts of our own country? You go to other parts of our own country, you might find people have exactly the same taste that you think causes your problem. Then they should have so much of ACE, right? That's not true. So food, what of that should be avoided? Maybe there is something there, but to date, science has not been able to differentiate and say, okay, this is really what is causing the trouble. Maybe we'll find something there. There is increasing awareness of the fact that our gut, the colon, is especially the small intestine, not colon, the small intestine is the seat for a lot of inflammatory diseases to begin. Our gut has what is known as the gut microbiota, which means the bacteria which usually stay in our gut. They interact with our immune system in a very interesting manner. They train our immune system to know what is self, what is my body, and what is outside my body. So you should understand, since you've asked this question, I'm going slightly into the detail here. You should understand that our gut and our respiratory tract, these are two areas of the body where our body's inner sides interact with the atmosphere. The food that we eat is outside world going inside and talking to our gut, telling the gut this is what outside looks like. And the body is trying to understand, the immune system is trying to understand, okay, if this is how outside looks like, anything from outside that enters me, I should kill it. But sometimes the bacteria that are talking to the intestines might act funny. They might act funny because of the kind of food, we don't know. They might act funny because of the kind of infections that they are. And they might mistrain or maltrain our immune system to say, nahi, 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 ye jo tumhare cells hai na, ye bhi foreign hai. And that's where autoimmunity might just begin. So there is a lot of interesting debate happening here, lot of work happening here, how things that our immune system is exposed to in the gut in form of maybe infections, maybe in form of food, but we have not been able to define which food, and what our respiratory tract is exposed to in form of things like smoking. Smoking is considered as one of the risk factors for a lot of autoinflammatory conditions like AS. So smoking or some kinds of food, some kinds of bacteria might be responsible. But as far as this specific question of food is concerned, I don't think we have reached a conclusion yet. We don't have an absolute answer as of now.
Okay, thank you so much, sir. So that brings us to the end of today's session. I, on behalf of Pharm D Community, would like to thank our honorable speaker, Dr. SUSHANT Shinde, sir, to delivering such an informative and elaborative session today. Thank you so much, sir, once again for accepting our invitation, despite the busy schedule that you have. Thank you once again.
Thank you so much, and best wishes to all of you.
Thank you so much, sir.
Thank you so much,
Goodbye,
sir.
and Jai Hind.
I would like to thank all the participants who have joined us for this evening talk. Thank you so much, everyone, for joining. The link for the certificate and the feedback form has been shared onto the chat box. So please, you can fill it. The link will be accessible for the next 15 minutes. So kindly fill the link as soon as possible. No personal messages regarding the link will be entertained. So please make sure that you fill the link as soon as possible. Thank you once again.
Yes, I would just like to add on, the certificates won't be emailed to you. You guys can visit our YouTube channel, and in the description of this video, that is ankylosing spondylitis, maybe you can check tomorrow evening, like after 24 hours, you can find your certificates uploaded over there. So we request you all to kindly download your certificates from there. Also, I would mention that the certificates are provided only to the live participants. Hence, we won't be entertaining any kind of personal messages or emails. The link will be open till, like, now the time is 6:50. So we can keep it open till 7:05, considering all your network issues. So kindly do fill in the feedback form and ensure that you've attended the session so that you receive the certificate. The same rules are applicable for those who have joined us on YouTube. I would like to thank everybody once again for joining us, and stay tuned and do attend our future webinars too. I'll leave this meeting on for about 5 minutes. So you can use the link for the gastroenterology series that's going to start from 13th of Feb. You can register for that, and you can also share it with your friends so that even they can take the benefit of the session. And also don't forget to fill the feedback form, all those who are on the on Zoom, like we've recorded your attendance.